Yes, sir, warm welcome to Mohan sir, HOD of Department of Dermatology. And Dr. Anand Kumar sir, HOD of Department of Pediatrics. The focus of today's session is to deepen understanding of dermatological concern in neonates. Today's session is an excellent opportunity to explore the dynamic relationship between neonatal medicine and dermatological care. We begin today's session with Dr. Rasul sir, consultant neonatologist. He will be presenting on the topic skin changes in neonates.
Today we will discuss about the common newborn skin changes. So as we all know, skin acts as a barrier and it protects even thermoregulation and electrolyte hemostasis also. There are many transient skin changes which we come across in our daily life, and sometimes we may get horrified because if you don't understand whether it's a benign or whether it's a problematic thing. And many of these changes will be transient and doesn't require any treatment. Sometimes parents will also get agitated like what is this and that. So if we know the diagnosis correctly, then we can convey them and counsel them that no need to worry. So this is just a milestone in the fetal skin embryogenesis where the expression of epidermal keratins will occur by 6 weeks, specialized cells by 8 weeks, and formation of dermoepidermal junction by 8 to 10 weeks, and the beginning of nail development by 10 weeks, and the hair development by 12 weeks, form of plantar sweat gland formation by 10 to 12 weeks, formation of fat in subcutis by 15 weeks, and sweat glands in 24 to 26. Impact of prematurity on skin physiology. So as you can see from this slide, the difference between the premature and term skin morphology. So pre-term baby's skin thickness is very less compared to term baby, and even the epidermal thickness is very less compared to term babies. And epidermal covering, there may be less vernis tissue, that is the small hairs which is present on the skin of the newborn baby. And transepidermal water loss is it may be very high in the preterm babies. It may, for in term baby it may up to 10 to 20%, but in preterm babies it may go up to 60 to 80%. More the premature, more the water loss. And acid mantle, which is like a protective mechanism for the skin, it may be incomplete in the preterms and like well developed in the term babies. And perfidence absorption may be erratic. So if we prescribe any ointment or any medication for the skin applied to the skin of the baby, like absorption may be very high in the preterm babies compared to the term babies. So we should be cautious about before prescribing. Even like Bethadine solution which we use for cleaning the skin also, it's contraindicated in the preterm baby because it can cause hypothyroidism. So can anyone guess what is the condition? So this is erythema toxicum neonatorum, a common condition affecting newborns, affects around 7 to 41% of the babies. Usually present from day 1 to day 3 of life. Is irregular shape erythematous macules that can develop more bowline vesicles and pustules. Most commonly affect the trunk, but can also involve the face and extremities as well. So as we discussed, no treatment is required for this benign condition. So we have to reassure the patients that it will resolve within some days to weeks. What is this? So this is transient neonatal pustular melanosis. So as you can see, there are the pustules, and this is more common in the dark skinned babies, whereas in erythematosus it can usually more common in the white color babies. This neonatal pustulomyelitis is more common in the darker babies, so more common in African American infants. There are three clinical phases. Initially, at birth, neonate has a very fragile and superficial 2 to 10 mm pustules located most commonly on forehead, under the chin, on the lower back, and on the chin. Next, the fine colloidal scales will develop around the pustules, and after that, hyperpigmented brown macules will develop at the previous pustule site. That hyperpigmented brown macules may be there for some time. It may take some months to years to resolve completely. So no treatment is required for this benign self condition, and we should know that hyperpigmentation may take months to completely resolve. What is this? So this is eosinophilic pustular folliculitis. So it is a vesiculopustular eruption. Whereas in transmesenteryma neoderm, usually rash will be there, pustule is not much. Here vesiculopustular eruption will be there. Infantile form is relatively rare and present with pruritic follicular lesions, typically on the extremities of scalp, although truncal involvement is described. Treatment is symptomatic and includes emollients, topical corticosteroids and antihistaminics. Topical indomethacin therapy was used previously. So this is eosinophilic pustular folliculitis. What is it? So this is basically in the legs and hands. So this is acropustulosis of infancy. So usually appears on the hands and foot. So relatively uncommon pruritic vesiculopustular rash occurs on hands and feet, spread to the wrist and palm. Eruption is more common in African American, Hispanic and Asian children and present at less than 1 year of age. Crops of intensely pruritic vesicles and pustules appear on hand and feet, persist for around 2 weeks and then resolve. Recurrent episodes of acropustulosis of infancy will eventually resolve around 2 to 3 years of age. So it may be there for long time. So one of the main differential diagnosis is scabies. Okay. And in newborns, scabies can even occur in the head and it can involve even head and face. So you should rule out the scabies, and if you are not confident, you can treat for the scabies also. You can try that. Topical treatment with mid-potency to high-potency corticosteroids is effective for discrete episodes, but will not help to prevent relapses. What is this? So this is milia, white, shiny. They are extremely common benign entity seen at birth at 40 to 50% of newborns. So these are tiny white monomorphic papules with smooth surface. They can number from several to dozens. Milia can present anywhere on the body, but occur most commonly on face, predominantly on the forehead, cheeks and chin. So treatment of milia is not required. They tend to resolve spontaneously over several months. What is this? This is like some rash with some white color. So this is miliaria. So usually we tend to confuse between milia and miliaria. Milia is like white, shiny thing. Miliaria is with R, where we can denote it as it's a rash. So it's a benign rash. It's due to obstruction of the eccrine duct occurring in the first 1 to 2 weeks of life with rapid resolution within days. Miliaria crystallina occurs when eccrine ducts within or below the stratum corneum are obstructed and causes small. Miliaria rubra is caused by obstruction of eccrine ducts at the level of epidermis and thought to be related to overeating. So this causes erythematous pustules or papulopustules primarily on the head, neck, face and trunk. No treatment is required for this benign condition which will self-resolve. Prevention of overeating can reduce the incidence of miliaria rubra. So first photo is something in the on the hard palate, and second one on the gum. What is this? Epstein pulse, and second one is bone nodules. So Epstein pulse and bone nodules are very common, and benign cyst in the mouths of neonates. They present as single or clustered 1 to 2 mm smooth white to yellow papules. Epstein pearls are found on palate, typically at the midline of junction between hard and soft palate. War nodules are found on alveolar region, most commonly in the maxillary region. Sometimes we tend to confuse with neonatal teeth from the bone. So spontaneous resolution will occur with time, typically within the first several weeks to months after birth. No treatment is required. What is this? Fine white things on the nose of the baby. So this is sebaceous hyperplasia. It's a common finding seen in approximately half of newborns. It's typically most noticeable surrounding the nose and upper lip. It presents as regular smooth white to yellow papules that can be grouped around follicles. Thought to occur secondary to maternal androgens which stimulate the sebaceous gland in utero. So no treatment is required and finding will spontaneously resolve in the first few weeks of life. What is this? So this is basically like a acne.
Recently you had a case in the ward. Some of you saw, no? I showed.
So neonatal cephalic pustulosis. So it consists of erythematous papules and pustules on cheeks, chin and forehead of infants. It occurs within the first 30 days after birth and can last up to several months. So comedones are usually absent, which we see in the adult patients. So it is an entity distinct from the infantile acne, which occurs at 3 to 6 months of age and can last for years. No treatment is required for this benign self-limiting condition. However, the lesion can take months to resolve. Topical treatment with imidazole antifungals such as clotrimazole, iconazole or ketoconazole may be effective at shortening the duration of eruption. What is this? This is seborrheic dermatitis. Newborn seborrheic dermatitis is an extremely common finding. Presents as irregular surmounting patches with waxy scaling on the scalp, forehead and nasolabial folds. Appearing around 2 to 4 weeks of age, usually resolves or abates by 1 year of age. Severe cases can become secondary infected. A strong association between atopic dermatitis and infantile seborrheic dermatitis has been postulated. So condition often resolves spontaneously or abates by 1 year of age. Both topical antifungals and topical steroids have been used to treat this condition. What is this? So one side is one color, another half of the body is another color. So this is called Harlequin color change. You could have seen the Joker like where one half is one color, another half is another color with the hat. So it represents an abrupt deep vascular red color change to one side of the body with contralateral blanching and sharp midnight demarcation. It can involve the entire body or can be more localized to single body area. It occurs most commonly in the newborn and is more often seen in premature infants. No treatment is required for this entity and it's benign and rapidly resolved on its own. So one more thing called Harlequin ichthyosis, which is entirely different. This is a benign condition. What is this? So what is another name for Mongolian spot? Dermal melanocytosis. Previously used to call Mongolian spot. If you see, read in the Nelson, they are told like avoid using the term Mongolian spot because it may be a racist. So it's called dermal melanocytosis, or one more name is salmon dermacytosis or slate gray nevus. It presents as well demarcated deep blue to grey pigmented macules and patches that are most commonly seen on the buttocks and low back. No treatment is required for this benign and self-limiting condition. It tends to fade over time with studies showing that 42% of cases disappear by 1 year of age.